Good afternoon. Good afternoon, everyone. Today I'm talking about trigeminal neuralgia. So, trigeminal neuralgia is also called as tic tolerance, trifacial neuralgia for the diseases. So, these are the synonyms or different names for trigeminal neuralgia, and that it is defined as it is a disorder which is characterized by severe paroxysmal burst of pain in one or more branches of trigeminal nerve, which are often induced by touching trigger points in or about the oral cavity. So this is a disorder which is characterized by severe outburst of pain in one or more divisions of a trigeminal nerve, which is often provoked or induced by touching a trigger point which are located in and around the oral cavity. So the most accepted etiology and pathogenesis for this trigeminal neuralgia are any underlying pathologies such as tumors of cerebropointed angle, demyelinating plaque of multiple sclerosis, vascular malformation. So these are the etiology and the pathogenesis under which most widely accepted cause is an atherosclerotic plaque of a superior cerebral artery. So this atherosclerotic plaque or a vascular malformation which causes compression or pressing and grooving at the level of the trigeminal root nerve. So this compression results into focal demyelination of the nerve, as a result of which the nerve becomes hyperexcitable. The nerve will be in a hyperexcitable state. So the moment the patient touches the area which is supplied by this nerve, there will be fire in response to that touch, as a result of which the patient will be having episodes of intense pain. So this is the accepted etiology for trigeminal neuralgia. Now coming to the classification of trigeminal neuralgia, so it is mainly classified into two types, that is classic trigeminal neuralgia and symptomatic trigeminal neuralgia. Now coming to the clinical features, so this trigeminal neuralgia is most commonly seen in individuals more than 50 years of age, that is older age group, it is most common. And this is characterized by episodes of shooting, stabbing pain, which last for few seconds only, and then the pain will completely disappear. And the patient usually describes like the characteristic of pain is usually electric shock like, and it is always unilateral. Trigeminal neuralgia is always unilateral, and it affects maxillary branch most commonly, followed by mandibular branch, and ophthalmic branch is the least affected branch amongst this trigeminal nerve. And the patient usually gives a history like a patient usually get the intensity of the pain increases, or the pain attacks starts on carrying out a routine activity such as chewing, smiling, shaving, touching, or talking. So these activities will increase the intensity of the pain or will provoke the pain. So this the pain is usually precipitated by slight touch on the trigger zone. So these are the zones, or the trigger zones which are usually located in and around the oral cavity on the face and even on the face, includes your nasolabial fold, the corner of the mouth, and the vermilion border of the lip. So these are the trigger zones which are common sites for the trigger zone. Usually by touching these zones, the patients will get the pain will get worsened or precipitated. And usually patient number of attacks usually vary based on the chronicity. So the attacks usually will be 1 to 2 per day, or even more than that also. So now coming to the diagnosis of the trigeminal nerve. So how will you diagnose trigeminal nerve clinically? So based on the history. So patient usually gives a history of shooting, electric shock like pain, which are present along the distribution of the trigeminal nerve, and which are precipitated by touching a trigger zone, which are usually located in and around the oral cavity, that is at the nasolabial fold, the vermilion border of the lip, and the corner of the mouth. So this is the typical history which a patient gives, and the patient usually also, covers his face by a handkerchief, so that and because of the pain which gets precipitated even while exposing to cold breeze also. So even while carrying out the routine activities also, the pain gets precipitated, or the pain attack starts. So this is the typical history which a patient gives with a trigeminal neuralgia. So this is the clinical diagnosis you can give based on this history. Apart from that, there is a criteria which has been given by White and Sweet in 1955, which is the most accepted criteria for the diagnosis of trigeminal nerve, which goes like this. First criteria is the pain is usually paroxysmal and sudden in nature. So the paroxysmal means the patient will be having episodes of pain, and it is usually sudden in nature. And the second criteria is light touch to the face in the trigger zone provokes the pain. So touching your trigger zone usually provokes the pain. And the pain is confined to the distribution of the trigeminal nerve. So the patient will be having pain only in the region which are distributed by the trigeminal nerve. And fourth criteria is this trigeminal neuralgia is always unilateral in nature. So those are the diagnostic criteria which are given by White and Sweet for the diagnosis of trigeminal nerve. So now coming to the investigation. So what are the investigation that you are supposed to carry out to diagnose trigeminal neuralgia? That is, first thing is MRI imaging. As I said, vascular malformation or any atherosclerotic plaque at the cerebral point in angle, or the tumors in your cranial cavity which are compressing your trigeminal nerve, those have to be ruled out. So those things can be ruled out with the help of MRI imaging. So apart from that, on chair side, you can go ahead with a diagnostic nerve block, that is injection of LA in the divisions of and the branches of a trigeminal nerve to rule out which branch of the trigeminal nerve is affected. So that is how you diagnose, how you investigate, how you carry out investigation to diagnose trigeminal neuralgia. Now coming to the treatment of trigeminal neuralgia, there are only two mainstays for the treatment of trigeminal neuralgia, that is medical and surgical treatment. So under medical line of management, we have certain drugs, so which are categorized as first line of drug and second line of drug. So under first line of drug, we have carbamazepine, phenytoin, valproate, baclofen, amitriptyline. Under second line of drug, we have gabapentin, oxcarbamazepine, lamotrigine, topiramate. So the first and most preferred drug for the treatment of trigeminal neuralgia is carbamazepine, which is started with a dosage of 100 milligram twice daily to a maximum of 200 milligram. You can increase until the patient responds. So once you, this is the flow chart which gives you a brief idea about the treatment of trigeminal neuralgia. So once you diagnose the case of trigeminal neuralgia, they are categorized as new case and refractory case. So refractory case are the cases which are chronic and which are not responding to this medical line of treatment. So once you diagnose the case of trigeminal neuralgia, you should start with the initial drug dosage, that is carbamazepine 100 milligram twice daily. You should advise and see the response. If the patient is not responding, then increase the dosage of carbamazepine to up to 600 milligram twice daily to maximum of 1200 milligrams per day. You can increase, or else you can also advise sustained release carbamazepine capsule at a dosage of 400 milligram twice daily per day. Even if the patient is not responding to this also, you can start with phenytoin also at a dosage of 100 milligram. If even after all this patient is not responding, then you can go ahead with combination therapy, that is carbamazepine, which is given the half the last dose. Suppose if you have given, if you have tried carbamazepine to a dosage of 1200 milligram per day, then half dosage of that, that is 600 milligram of carbamazepine along with phenytoin sodium 100 milligram should be given, or else oxcarbamazepine 300 milligram twice daily per day to maximum of 1200 milligram per day can be given, or gabapentin can be given at a dosage of 300 milligram on first day and once daily, and 300 milligram twice daily on second day, and 300 milligram thrice daily on third day, and then maintain this dosage only, and it can be increased to a maximum of 2400 milligram per day. So this is how medically you can treat trigeminal neuralgia along with a different drug of choice, or you can go ahead with the combination therapy if the patient is not responding to single drug. Even after combination therapy and a single drug, also patient is not responding. You can start with a second line of drug, that is lamotrigine, pimidazine, or baclofen 25 milligram twice daily per day. So even after trying all these drugs, patient is not responding, then you can go ahead with surgical line of treatment. That is surgical treatment which is given for the trigeminal neuralgia is percutaneous radiofrequency thermocoagulation or microvascular decompression, or you can also uh, start with gamma knife surgery. You can also do for this trigeminal neuralgia. So this is how a trigeminal neuralgia is manifested, diagnosed, and treated. Thank you.